Hi, my name is Kim Gerke. I am a hospice nurse working in the Milwaukee area. Today I would like to talk to you regarding terminal illness and care of the hospice patient. First, I'll give you a little bit of what hospice is. Hospice is a philosophy of care, and the goal of hospice is to give comfort and dignity to someone who is dying. Who is eligible for hospice care is someone who is terminally ill with the prognosis of 6 months or less. Hospice care can be provided both in the home, in the hospital setting, long-term care facilities, or in freestanding hospice residential facilities. What is available in hospice care is you are given care by a team of caregivers, nursing staff being that of the RN case manager, healthcare assistant, social worker, chaplain, and the primary care physician, as well as volunteers. And there's also speech therapy, occupational therapy, and physical therapy if that's something that's deemed appropriate for the person's illness. The goal of hospice, again, is to make the patient comfortable. Pain management is the #1 key, and dignity. We want to do specifically what the patient desires. Another goal of hospice is to assist the patient and family in making legal and financial agreements, which includes advance directives, both the living will and the power of attorney for health care. These are written up specifically for the patient to make their wishes known regarding care with end of life when they're no longer able to speak for themselves. They can be very specific as to stating that the patient does not wish to have any kind of resuscitative measures done for them, be put on a life support, and they have the right to withdraw feeding tubes and things of that nature. Your role as a healthcare assistant, I will go a little more in depth with, and I'll start with the area of respecting the choices and the rights of the individual. It's very important for you to know that in hospice care and care of the terminal patient that the family and the patient are both involved in making the plan of care. So it's very well written out by the nurse and the family what they do and do not want, and you need to respect that. You want to encourage self-care as much as possible. If the patient is still able, remember that we want them to have quality of life. We don't want to take everything away from them. We want them to do what they feel they can do. So involve them in their cares. Example of letting them wash their upper body while you wash their lower body. And encourage family also if family wants to be involved. Family can be in there, not necessarily washing, but I frequently ask family to come in and participate in doing the massaging of the patient while I'm doing something else with them. You want to report any signs of pain or discomfort to the RN case manager that you may notice during doing cares with the person, be it they moan or grimace or something, and you can ask them if they're having pain. They may at some point deny it, but make that aware to the nurse so she knows what to look for when she is assessing that patient. You want to listen and be very honest in your discussions with them. Let the patient talk. Don't disagree with them, and you don't want to feed into anything negative. Just be an active listener and let them know that you're there to support them. During this time with them, you're gaining their trust, which is very important towards the very end of life. Quality care, you want to give this individual the same kind of care that you would give anybody who was not given a terminal diagnosis. They're living each day as if it was their last, so you want it to be the best that it can be for them. The physical signs of approaching death that you will note, the body does begin to start to slow down. You will notice the patient may start to be sleeping more or may want to eat less. For appetite decreasing, that's a very large area for families. They find it very difficult to not feed their patients. We're all grown up. When we were growing up, we're taught you have to eat to be healthy. And a lot of families have a difficult time with that. The way you can help is to give suggestions to the caregivers that they can offer small meals. People will be more open to trying something if there isn't a large amount of food on their plate. As someone's dying, they no longer have that desire to eat. So when they may view it, and I've had several patients tell me that if they don't clean their plate, it's it's a sign that they are dying, and we don't want them to have that feeling. So you want to offer frequent smaller meals. People also tend to crave colder foods towards death. You want to offer ice chips or sherbets or cold water, but again, at a very small amount, because their swallowing can also change as their body shuts down. Thicker things are usually tolerated much better than thinner things are, so I usually tend to stick with the sherbets and pureed foods or things of that nature, but refer to your nurse and ask for her guidance, and she will put that in the plan of care so that you know where you're at with that. Circulation also decreases as someone is declining, which is all part of as they become less active, they're lying around more, their body is conserving its energy, and the oxygen is focusing more on the vital organs in the body. You may start noticing changes in the skin color. Skin may become what we call mottled. It's a purple reddish blotching of the skin that can come and go. Family members may frequently ask if oxygen would help that, and normally the answer is no. Again, oxygen is a comfort measure. If the patient wants it, they're welcome to it. If not, they can decline that. They may become less responsive. Again, as the body shuts down, the kidneys and all of those vital organs that normally filter out the toxins in the body are no longer functioning at the capacity that they once were, so you'll notice a decrease in urine output, which is a sign that the kidneys are starting to fail, and those toxins are starting to build up in the body, which is kind of your body's own natural response to an anesthetic. It kind of puts you in that sleep. It does make you sleepier, which is a good thing at times where people don't require as much pain management. Their skin will become much more pale and dry at times. Their temperature can fluctuate. It's very important that you want to do frequent oral care, and with toothette sponges, if they're no longer able to swallow, that's a form of hydrating them. Their mouth becomes dry because they are normally mouth breathing at this time. You want to keep their skin moist by doing frequent massages with lotions and turning them from side to side. Temperatures are not always treated unless they appear to be a discomfort to the patient. The normal way that we treat them is just either cool tepid baths or just cool cloths to the forehead or to the extremities. You want to keep the lips and moist, very lubricated. There's several things out there. You can either use water or cool washcloth. You can use chapstick or Carmex, and we use, where I work, a specific moisturizer that can be used both on the lips and the inside of the mouth. Again, refer to your nurse and she can help guide you through that area. Repositioning, again, you want to pay particular attention to the bony prominences of the body, because that person is now losing muscle tone and the inability to move themselves. Those areas are pressure points that you want to pay close attention to, because skin can start to break down quite quickly in those areas. Loss of bowel and bladder control is often very common. You want to make sure that that person is, again, you're maintaining their dignity and comfort. You want to do excellent peri-care and anal care. You want to, because the urine is much more concentrated towards end of life and can cause skin to break down much quicker. So you want to be very thorough in cleaning those areas, and possibly speak to the nurse about the patient's wishes or desires of possibly having a Foley catheter put in. Many patients at this point in time, when they reach this level, are quite agreeable to that, because they don't want, and family members, because they don't want any breakdown. You want to apply protective barrier creams as frequent as possible to, again, prevent any skin breakdown. You may notice breathing changes, irregular shallow breathing, and this is oftentimes associated with temperature fluctuations in the body. It's a very normal response. You may notice them breathing very rapidly, and you may notice them having periods of what's called apnea, where they stop breathing for up to a minute at a time. that is very normal, and that can go on for quite some time. Again, the best thing you can do is just be there and reassure the family that this is normal, and you'll do everything you can to make sure that they're kept comfortable, and the way to keep them comfortable is by doing the oral care, and that because of the breathing changes, they do become very dry. Normally when they get to the very shallow breathing stages, they really are not able to take sips of water, and that's where you really want to work closely with the family and the RN case manager regarding what is appropriate to give and what is not appropriate to give. You want to elevate the head of the bed and keep them in a semi-sitting position. That does help for better lung expansion for the breathing that they are doing. They may request oxygen and are able to have that. Again, that's something that the nurse has to get an order for, and that's not a problem. But once oxygen is put on, that does cause more dryness. So again, you want to encourage the family when you're not there. Obviously, you won't be there 24 hours a day. The correct way of doing good oral care. One family, just to let you know, was giving them instruction because they were very fearful. They wanted to keep giving drinks of water, and I said, well, I asked what the person's favorite drink was, and it happened to be Coke. I said, we can use the Toothets in Coca-Cola also. You can put those Toothets in anything where it feels that the family may feel better that the patient is getting something that they like, and then just instruct them on how to get as much of that liquid out of the Toothet as possible, because a natural response when you're swabbing someone's mouth who's semi-comatose or alert is that when you hit the roof of their mouth, they will bite down. So you don't want to pull on the Toothet when they bite down on it. You just kind of want to let it sit there for a little bit, and then their mouth will naturally relax, and then remove it, and encourage the family to do that. We don't want anybody biting off the tips of Toothets and have the possibility of choking. Visual and hearing changes. You may notice that the patient may have a blank stare on their face. Their eyes may begin to tear. They tend to not blink as much. Their eyes may stay open or closed, but tearing is a normal response. If tearing stops and the eyes do look dry, it is okay to use artificial tears or something of that nature. But again, check back with the nurse manager or case manager, and she will guide you in that area. Hearing, I can't tell you enough or express enough how much I've witnessed since I've been in this area, that hearing definitely, to me, has been proven to be the last thing to go. You want to treat that person with dignity, and if they appear to be sleeping, you make sure that you tell them everything that you are going to do for them. If you're going in to bathe them, you let them know what you're doing, what area you're bathing, that you're going to turn them or massage them, play music, and encourage family to talk with them also. It's not unusual to see family members sitting around and just staring at the person saying they don't want to wake them. It's the best time for them now to say whatever they want to say to that person and encourage them to look for responses. That patient may no longer be able to verbalize what they're feeling. They don't have the energy just because of how their body is shutting down to say what they want to say. So I always tell families to look at other cues, as look at the eyebrows. When they say something, I ask them to share something that's very personal that only they and that person would know, and watch for the eye to move or their lip to curl just a bit. You know, that's a response that that person is responding to them. They just can no longer verbalize it. And that is a great comfort to family members. And I have yet to have a time when I've asked someone to do that where there hasn't been some response. You want to regulate the environment in which the patient is in. Make sure it's appropriate. If the patient is running a temperature, you don't want to have them under a lot of blankets. A lot of families really want that. But if you just take a little time and explain to them that it's normal for their temperature to fluctuate, that if they feel too warm, it's okay to remove the blanket or open a window for a little bit or have a fan. TV and music, if that's something the person was always accustomed to, there's no reason to stop that at this time. Frequently at the hospice home or just about a year ago, everybody was into Wheel of Fortune, and I remember at 6:30 running around the residence and putting Wheel of Fortune on everyone's TV, be it that they are awake or not. And I would always talk to the people walking in saying, you know, let's not buy a vowel today or something. Humor is great, and wherever you can put humor in, it's a great barrier breaker between yourself and the caregivers, as well as for the patient when they are able to respond. No one likes to be serious all the time, even the person who's sick. Signs that you'll know that death has occurred is that you will, again, notice that blank stare. Notice that the breathing will have stopped. If you can, take your hand and try to put the eyelids down, if possible. There will be no pulse. You'll, again, notice no breathing. You may notice a loss of bowel or bladder control. And the jaw, usually by this time, is hanging down because they have been mouth breathing for quite some time. You want to notify the nurse as soon as possible, or if you know that you just have that feeling that death is very imminent, and you can tell that by respirations that have slowed down to about 4. Make sure that the nurse is aware. The nurse will be the one to notify the physician, and she will come out to the home or wherever you're at. The nurse will be the one that will do the definite, look over the body and make sure that all vital signs have stopped. Again, you want to be there to comfort the family and encourage them, even though the patient is no longer alive. I still encourage them to say whatever they would like to say, give a hug if they want to give a hug, and they will have a chance of viewing the body again. The nurse will take the patient's family and talk to them, and that's when your key role is to come in and prepare the body or do post-mortem care. What I really want to stress is that as being part of the team, that you find out as early as possible in your care of this case, of a case, is to find out the person's religious background and cultural beliefs, because this does play a very important role in how you prepare the body in end-of-life care. Examples that I can give you are some cultures require that the body be washed with special oils or lotions first, or another culture may say that just the family can do post-mortem care. Again, that is something that we have to abide by because that is their beliefs and wishes. And other religions, I know that post-mortem care needs to be done within a certain time frame after the pronouncement of death. So make it known that you are part of the team, and if someone does not give you that information, that you seek that information out, because it's very important, and it'll give you a sense of comfort in the care that you give also. Which leads me where I'm into the communication with the team. It's very important to always communicate. Whatever you see, whatever they see, there should be that communication going all the time. What you want to do for postmortem care is, what you're doing is preparing the body to be sent off to the funeral home. You want to put on gloves before doing any type of care with the patient. Close the eyelids, which I did mention earlier, and many times I'm in the room with the person and I don't always have gloves on when I'm doing personal touch when someone is still alive. With the gloves on, you want to put in the dentures if they have them, and try to close the mouth if possible. If their mouth has been hanging open for a while, you can use a rolled up towel to place under their chin to support the jaw so that it goes into the natural position. You want to wash the person's body, and wash with the same kind of care that you gave to that person while they were still living. Talk to them, let them know that you're cleaning them up, and that their family will be coming in again shortly afterwards. Again, dignity and respect. If you're doing the care with another individual, please don't do chatter over this person's body. It's still an individual there. You want to just do cares for that person, have soft music playing, but don't speak of your private lives now. Is not the appropriate time for that. If the patient has an indwelling catheter, you would be removing that at this time, and the nurse will give you instruction, or you'll get instruction, and your courses on how to do that. You want to put on a disposable brief because as the body does shut down, you never know when any other fluids will be expelled from the body. So after the body is completely cleaned, put on a disposable undergarment and a nice, clean, fresh gown. You'll want to cover the patient's body with a fresh sheet, and I like to place their hands outside of their body, either across their lap or at their sides. I leave the side rails down on the bed and invite the family in to spend a little more time with them if they so choose. You want to offer your condolences to the family, offer your support, and it's okay to show emotion. If you felt particularly attached to that person, that's fine, and that shows the family that you truly cared and you're only human. And it's impossible to not let feelings come in the way sometimes. If you are working in a facility rather than in the home, you want to check the facility's specific guidelines for tending to the person in postmortem care. They have certain things regulations that they need to go by, so it's very important to check that when you're starting someplace, what their requirements are. And if this is your first experience with a dying patient, make sure that you have someone else with you. It's very important. You don't want to be doing that alone. The last area to be discussed on this video will be that of organ and tissue donation. And I would just like to extend best wishes to all of you as you start out in this new rewarding career. You'll love it.
Thanks, Kim, for that very important information about terminal illness and hospice care. Hi, I'm Kathy Getrist, and I'm an instructor in community health. The subject that I want to talk to you about is a very sensitive but a very important subject. It has to do with organ and tissue donation. We all want to leave this life feeling that we have been remembered. Remembered for who we are, remembered for our accomplishments, and remembered for the differences that we've made here on earth. One way that we can make a difference is to learn the facts about organ and tissue donation, and that's what I would like to do right now. Did you realize that tens of thousands of Americans currently are waiting for a life-changing or a life-saving organ? Thousands of others wait for tissue transplants. These tissue transplants can help relieve pain, help improve mobility, and help restore eyesight. Wisconsin, as many of you know, has been historically a leader in organ procurement. Even though we have been a leader for years, several thousand people are on the waiting list here in Wisconsin, and many will die because organs would not have been found for them. As just one person, we can give up to 50 people the gift of life or enhanced life if we're willing to become donors. With advances in medical technology, many more people than ever before can be potential donors. People that are older than 70 years old. Almost anyone can be a potential organ donor. Some of your patients will have made the decision upon death to donate their organs and tissues for medical research or for the organ and tissue donor program. Their directives will be part of their medical record, also called the chart. It's your responsibility as a healthcare assistant to be certain that you support the patient's decision to be involved in this donation process, as well as their families. Any special care of the body that will be required after death that you might need to be involved in will be discussed with you by the nurse that you are working with. Now, you might want to know how you might become an organ and tissue donor upon your death. The process is really very simple. I think the most important thing is to discuss this as you would any important issue with your family. The subject came up in our family when my older daughter was a senior in high school, and she had a subject that dealt with organ donation. She came home from high school all excited and said she very much wanted to be an organ donor herself, and said, "Mom, what about you? And Dad, what about you?" Well, quite honestly, it caught us off guard, but it got us thinking and talking about the issue. After we talked about it at some length, we decided, yes, in fact, this was a good thing to do. And so what we did is we put our names, we signed our names on the back of our driver's license. The back of the driver's license has a section called Anatomical Gift Statement here in Wisconsin. And you can sign this over the plastic, and that's one method of letting your wishes be known. Another way that you can let your wishes be known is if you happen to have, as Kim was talking about previously, the advance directive. The advance directive for health care or the living will allows you to indicate that upon your death you would like to be an organ and tissue donor. A way that you can become a donor to let those wishes be known is by signing a donor card. These donor cards can be obtained by contacting the Wisconsin Donor Network, and they would be more than happy to provide the card for you. Making decisions about your future wishes, whatever you decide, is something that is very important to do. It's important for your loved ones, and it's truly a gift to your family. Talking about your wishes will save your family heartache in having to make those decisions after your death, and it will provide them with the reassurance that your wishes at the end were very much respected.